We're going to go ahead and get started. At the end of Grand Rounds today, we have more Teaching Excellence Awards, so I just want to give Drs. Duchin and Scott enough time for Grand Rounds. So I'm going to introduce each of them separately. Dr. Duchin is currently the Professor of Medicine in the Division of Allergy and Infectious Disease, as well as an Adjunct Professor in the School of Public Health. He's also the Chief of the Communicable Disease Epidemiology and Immunization section at the Seattle and King County Public Health. He got his medical degree at UMDNJ in Newark, New Jersey, and completed his internal medicine residency at Jefferson before going on to have multiple fellowships and additional training experiences at the CDC before coming out to Seattle, where he did his ID fellowship. He currently has many local and national responsibilities, including with the CDC and the World Health Organization. He is the chair of the Public Health Committee for the Infectious Disease Society of America. His research interests focus on communicable diseases of public health significance. He has authored over 50 peer-reviewed original publications, nearly a dozen book chapters, and many other publications, including some of the immunization recommendations. Dr. Scott is currently the Associate Professor in the Division of Allergy and Infectious Disease. He is also the Assistant Medical Director in the Hepatitis and Liver Clinic at Harborview, and is also the first Medical Director of Telehealth at the University of Washington. He achieved his medical degree at Georgetown and then went on to Stanford, where he completed his internal medicine residency, and then came out here for his infectious disease fellowship and also got a master's in epidemiology during that time. He has extensive research funding for viral hepatitis programs. In 2009, he launched the Project ECHO here in Washington State, and for those of you who aren't as familiar with it, it's a telehealth program that helps clinicians serving in rural and underserved areas with the evaluation and treatment of hepatitis C. He also has dozens of peer-reviewed original publications and has been invited, as has Dr. Duchin, to speak locally, nationally, and internationally. So please help me welcome both of them to the podium for their joint Grand Rounds.
Well, thank you. That was a very impressive mastering of our bios. It's a pleasure to be back at Grand Rounds and talk about something other than Ebola. This morning, John and I will be talking with you about the most common blood-borne virus in the United States, the most common cause of chronic liver disease in the U.S., and share with you some data that suggests that there's something that we can do to forestall the tsunami of complications that's headed our way due to hepatitis C. These are our disclosures. Unfortunately, I still have nothing. So this is the problem. Millions of Americans have hepatitis C. Most don't know it. So we're going to try and help you do something about this. There are between 2.7 and 3.9 million people in the U.S. with hepatitis C infection, and up to 75% don't know they're infected. And these people, therefore, are at risk for serious complications: liver disease, hepatocellular carcinoma, liver-associated death. Only half of those with hepatitis C receive complete testing, meaning that after an initial antibody screen, they receive the recommended RNA test to determine whether they have an active or current infection. And the vast majority of persons with HCV are baby boomers born between 1945 and 1965. And this shows the prevalence of hepatitis C antibody by year of birth, and two NHANES studies during different time periods, and you can see that the individuals born during the baby boomer cohort have a five-fold higher prevalence than other U.S. adults. And in particular, there are sub-cohorts, such as black men born between 1950 and 55, that have even higher prevalence. So this is another way of looking at the baby boomer cohort, which accounts for 3/4 of the HCV and 70% of our HCV deaths in the U.S., the number with chronic infection. So the axis, the y-axis is the number in millions of chronic HCV infections. And you can see that those born in the 1950s are the main risk group, but also the 60s and the 40s contributing. And if you look at the other ends of the birth cohort spectrum, relatively few much lower prevalence, but relatively few persons have HCV. So unfortunately, among all these, I love that song. Thank you. I used to put that. So Unfortunately, I've told you that so many baby boomers don't recognize they have HCV, and it's a sad fact that among those that don't recognize they have HCV, many of them have significant liver disease with advanced stages of fibrosis and cirrhosis, and John will talk to you more about that. So this slide from Ryan et al. Shows us what we're looking at in the context of significant chronic hepatitis C complications. They looked at a birth cohort, a prevalence through 2004 only. So this represents persons who are diagnosed with Hep C through 2004 only. So we've got many more that aren't represented here. But of that cohort of 2.7 million HCV persons who might be in primary care, almost 1.5 million will develop decompensated cirrhosis, 350,000 will develop hepatocellular carcinoma, and almost 900,000 will die from HCV-related complications. And you can see that we are very early in this stage of oncoming and pending complications and death due to hepatitis C. And this is through 2060. So these are people born through 2000, or infected through 2004, and these are the complications predicted in the absence of therapy through 2060. And if you haven't heard, back in 2007, hepatitis C passed HIV as a cause of mortality. So hepatitis C now is continuing to separate itself by remaining as a higher cause of age-adjusted mortality than HIV in the U.S. And this is just some local data to show you that, indeed, we are seeing HCV deaths here in Washington State, and our age-adjusted death rate, represented by the line in the axis on your left, is approximately what's seen nationally, about 7 per 100,000. And we're experiencing hundreds of deaths each year in Washington that are recognized as hepatitis C. And in King County, we have approximately 1,200 persons reported with chronic hepatitis C each year. And as nationally, this just shows you that locally we have a large proportion of our reports represented by the baby boomer cohort. Now, the national surveys are more accurate because we don't do the type of testing that we need to do among the baby boomers here to recognize most of the prevalent cases. But even without the necessary testing of the baby boomer cohort that we're recommending, we're seeing 54% of our cases are in that cohort. And so when we talk a little bit about some of the interventions that we're going to be doing, it's based on the fact that we have about 500,000 baby boomers in the county among our population of almost 2 million. And we estimate that out of those boomers, about 10,000 have chronic hepatitis C infection. And in addition to that, we've got a cohort of about 43,000 persons who inject drugs or have injected drugs, and about 16,000 of those probably have chronic hepatitis C. So this, I think, is a really important article from a recent issue of Hepatology by Razavi. Basically, what it shows you in the blue is the prevalence of hepatitis C, which peaked around 1994 at between 3 and 4 million cases, and has been decreasing since that time. However, there's a delay in the incidence of societal cost and healthcare costs associated with chronic liver disease, decompensated cirrhosis, hepatocellular carcinoma, and liver-related deaths, so that the peak of those complications will come 30 years after the peak in prevalence of hepatitis C. So even though the incidence has been declining from as much as 250,000 to 500,000 new cases a year in the late 80s and early 90s to just a couple of thousand cases a year currently, the incidence of severe complications is rising and hasn't peaked yet. And we can do something to minimize this burden, to prevent this huge burden of potential chronic complications of hepatitis C through appropriate screening and treatment, and that's a lot of what the focus of the remainder of this talk is going to be about. But in the absence of that treatment and screening, the estimated cost of treating the complications of hepatitis C is staggering and will peak in a couple of years at $9.1 billion. And the lifetime cost of just every individual with Hep C in 2011 was estimated at about $65,000 and is higher for those who live longer. So for these reasons, a couple of years ago, the CDC and the U.S. Preventive Services Task Force recommended every baby boomer have a screen for hepatitis C. And in addition, the other major risk factors for hepatitis C also should trigger screening, which you're familiar with, such as blood or organ transfusions or donor before 1992, blood products before 87, and so on. So the many benefits of this birth cohort testing strategy include being able to identify the majority of cases, to provide screening for the stage of liver disease, to counsel and educate patients on how to decrease or eliminate alcohol consumption and reduce interactions between medications and herbal supplements they may be taking to protect the liver, to encourage weight loss for persons who have elevated BMI because insulin resistance and obesity are related with accelerated stage of fibrosis, as is diabetes, and to vaccinate them against hepatitis A and B, but primarily to reduce hepatitis C-related morbidity and mortality. And it's been shown in a number of studies, and I'll show you a few, that a sustained virological response to treatment is associated with a very high reduction in the risk of hepatocellular carcinoma and the risk of liver-related mortality and liver transplantation. In addition, treatment will reduce symptoms and mortality from the severe extrahepatic manifestations of Hep C. So this is a recent study, also a very good one to look at in the Annals of Internal Medicine, that looks at the probability of cost effectiveness of sofosbuvir and ledipasvir by willingness to pay threshold. In other words, how much is it worth to you to get improvement in a quality? And usually in the U.S., we're recommending treatments that fall between $50,000 and $200,000 willingness to pay threshold. And what this shows us is that at a threshold of $50,000, treatment-naive patients who have cirrhosis have a very high probability of cost effectiveness, well above 80%. And even at a threshold of $100,000, many patients are likely to be experience cost-effective treatment. So when you look at the various cost thresholds, you can see, to put that dot away, that even if you send out to $150,000 willingness to pay threshold, which is not uncommon in the U.S., most patients with Hep C, whether they're treatment experienced or treatment or naive, with or without cirrhosis, will have cost-effective treatment. And just one more kind of, interesting article from January 2012 showing us the association between sustained virological response and all-cause mortality. So here, all-cause mortality, the top of the graph in each of these tables is 50%. So all-cause mortality without sustained virological response and with, liver-related mortality or liver transplant without virological response and with, hepatocellular carcinoma without and with, and liver failure. So sustained virological response seems to be associated with a very profound improvement in prognosis. Now, this is a function of the progression in treatments that have been available for chronic hepatitis C, beginning with interferon back in the 1990s, which only had a sustained virological response rate of 7 to 10%. Coming through the combinations of interferon and ribavirin, and better formulations of interferon and ribavirin, the most recent combination before our direct-acting agents, producing a sustained virological response of 60 to 70%. And now these new drugs, which Sean's going to talk to you in detail about, with very high sustained virological response rates. So we're trying to now change the paradigm and look at HCV more like the way we treat HIV. We want to look at this as a care continuum where we assure that the patients who are infected are diagnosed, that they're engaged in care, that they're prescribed appropriate treatment, and that they're virally suppressed. In the past, these people have been floating around. They and many physicians have been more or less nihilistic about treatment because treatment has been difficult and not associated with extremely high cure rates. So looking at how we're doing in the U.S. on this front, we can see that the treatment cascade for people with chronic HCV infection does not look as good as it does for HIV. So among those who have chronic HCV, only 50% are diagnosed and aware, only 43% have access to care, 27% have had their RNA test to confirm active infection, 17% underwent liver biopsy, or this could be staging of liver disease, 16%, only 16% received the appropriate treatment, and 9% achieved a sustained virological response. These are the corresponding national levels for HIV, although in King County, thanks to Dr. Goldman and his team, the HIV SVR rates are more like 70%, so much, much higher than the national average, but still the contrast between HIV and Hep C is striking. So, because of all this, John and I, and with help from Matt and others, applied for a grant from CDC. We were awarded one of three. It was a $6 million four-year project to improve the diagnosis and treatment of persons with hepatitis C. I'm going to tell you a little bit about that, and then John's going to talk in detail. So the goal of this project is really to build a sustainable public health and healthcare system infrastructure to increase the number of persons identified, evaluated, treated, and cured with chronic HCV. And there's a collaboration between my public health agency, the University of Washington, John, and many community healthcare providers, including HealthPoint, community health centers, Neighbor Care community health centers, Harborview, Group Health, and Swedish, Department of Health, the Washington Healthcare Authority, and the Hepatitis Education Project. And the target populations are the recommended baby boomer cohorts for screening in persons who inject drugs, low-income persons, under and underinsured, and racial and ethnic minorities. And we're capturing a lot of these through participation of the federally qualified health centers, the community clinics. So these are the key elements of our project. We're going to use clinical decision support by taking advantage of the wonderful electronic health record. And we're going to use EHR-based interventions to systematically identify persons who are eligible for testing in a standardized way, and to monitor and evaluate the indicators of that testing, the linkage of those persons to care, the staging of their liver disease, their treatment status, outcome, and other recommended interventions such as alcohol counseling and intervention. So this is going to be an HCV care continuum, analogous to what we do for HIV. We'll expand treatment capacity through provider training and through consultation that John is taking the lead on. I'll share that with you. We'll implement RNA testing in our local laboratories as a reflex test, so that now it has to be specifically requested, unlike HIV, where you order HIV testing, you get an antibody and then a viral load screen. We like to have the same thing done with HCV, so if you order an HCV antibody, the patient gets an RNA test automatically. We'll establish case management. You've probably heard that case management team approach is a very effective model for monitoring and managing complex chronic medical conditions, and HCV is no different. We're going to improve our ability to do surveillance and investigate cases, provide community and provider education to raise awareness about diagnosis and treatment, and promote access to care through making sure our target population gets enrolled in ACA, Obamacare. So what we want to establish is this continuum engagement in care, very analogous to what we have for HIV, where patients go from not in care and unaware of their status to fully engaged in getting the appropriate medical care. I want to just sum up here by making you aware of outstanding resources that are available to you, if you're not already aware, at the CDC website. They've got great handouts on who should be tested, handouts on drug use, just a whole plethora of very useful information for healthcare providers and patients. So I'm going to turn over the podium to John now for additional detail about our project and treatment and staging.
All right. Well, thanks, Jeff. So Jeff kind of set the stage for what's going to happen if we don't really address this problem, if we don't improve our screening and uptake of treatment. So I'm going to talk a little bit about some of the clinical issues. How can we stage people in a cost-effective and easy way, and then turn to the treatment, which is really one of the exciting things that have occurred. So I think for many years we relied on liver biopsy to stage patients. This is a procedure that we do as an outpatient. It takes all of about a couple seconds, but there's a lot of process to do that in a safe way, so they're usually here for the whole day. And it goes to the pathologist, and they do a trichome stain, and it's scored from 0 to 4, F0 to F4. And in the upper left there, you can see an example of a very nice, pristine liver. And then on the second panel here, you start seeing a little bit of aqua color, which is F1. And then here is an example of what's called bridging fibrosis, or F3, and then cirrhosis over here. So in general, we've preferred to treat the F3s and F4s because we know from the natural history, if you don't do anything about those, they're the ones who get in trouble, have liver failure, or develop liver cancer. However, I think we've learned over the years that liver biopsy is not such a great gold standard. And part of the problem is just you're sampling a very small portion of the liver. So in a study in which doctors did a percutaneous liver biopsy and then did a laparoscopic biopsy on multiple sites, they found disagreement about 10 to 15% of the time. And so I just want to make sure that you all know that you need to get a good sample, and that's usually 2 centimeters or more than 10 pleural triads. And if you ever see a report where there's fracturing, that's usually a tip-off for cirrhosis. So it can miss the diagnosis. It's an invasive procedure with some very small risk of bleeding. Yeah, and it's not that cheap either, $2,500. A lot of patients will do it if you really twist their arms, but if you give them other options, they're much more likely to take those. And the last thing I would just say is that even if you have a good sample, a lot of times there will be two pathologists who will disagree on what the reading is, as much as 20% of the time. So what we've been doing more at the liver clinic is the reliance on blood tests for diagnosis of fibrosis, and there are probably more than a dozen that you could order. I have bolded the two that I would suggest you use just because they're probably the most well-substantiated and probably the cheapest. And the first one is the APRI ratio, which is AST to platelet ratio, so just get an LFT and a CBC. Pretty good sensitivity and specificity, especially for diagnosing cirrhosis. So if you have a high APRI score, then that can really nail the diagnosis. FIB4 is very similar to the APRI. It just takes into account age, so you could do that as well. And then the other test that I wanted to highlight that's available at our labs is something called FibroSure. It is testing different components. It's a proprietary algorithm, but it's testing like apolipoprotein and beta-2 microglobulin and other things. So it's a different test, and it also has quite good negative predictive value and decent positive predictive value. So if you're an outpatient doc and you have a Hep C patient, you want to kind of know where they are, ordering an APRI and a FibroSure that's going to be probably around $300 is a great way to kind of triage them and then referring them on to us if that's what you want to do. We have a good indication of whether they need treatment right away. So the other thing I want to let you know about is there's been a lot of advances in radiologic diagnosis of fibrosis. For many years, the ultrasound has been the only option there. Is good if you have a read saying there's macronodular cirrhosis or nodularity, then that's believable, especially with splenomegaly. But what we've been using more and more is something called transient elastography. The commercial name is FibroScan. It's just measuring the stiffness of the liver. And we have a similar test called ARFI. So this is just a modified ultrasound device that we have here at both the UW and Harborview. So that's a third non-invasive test you can use. MR elastography shows lots of promise. I still think trying to work out the details, but that might be something that's going to be in our armamentarium in the coming years. So next I want to talk about treatment, and I love this cartoon that was published in Hepatology last year. And for those you can't see, you have a Godzilla-like creature here that says Hepatitis C, and then a bunch of scientists, including, I think is that you, Jeff, right there? It says, it took us 25 years to bring him to his knees, now let's finish him off. So I don't know if you realize this, but Hep C was discovered in 1989 by Mike Houghton down in Northern California. And in 25 years, we have come to a treatment that's almost 100% curative. I think it's one of the greatest success stories in medical science, and so it's a lot of hard work of many different people. It's a really exciting time. So I wanted to just give you a broad overview of what the national guidelines are for treatment of hepatitis C. And this is a very nice joint statement between the Infectious Disease Society of America and the American Association for the Study of Liver Disease. So hepatologists and ID docs like myself got together. And the first thing I want to point out is the very first thing in their document, in a box, says all patients should be considered for treatment of Hep C. Okay, so that's the first thing they say about treatment. The second thing they say is that we know these treatments are expensive, so if you're trying to triage or trying to prioritize, then this table is often a good way to think about it. And the highest category of patients are those who have F3 and F4, because they're going to get into trouble. Anyone who's had organ transplant, because their immune system is suppressed and they're more likely to encounter liver problems. And then I think these next two categories are something that we don't always think about. Because Hep C can cause extrahepatic manifestations, cryoglobulinemia. It can affect the kidney in particular, so glomerulonephritis. So if that is going on in your patient, then they will often be prioritized by insurance companies. So unfortunately, I think a lot of payers have seized upon these guidelines and have said, hey, we're only going to pay for highest. That's where we're going to draw on the line. And this is a somewhat arbitrary distinction here. I just want to let everyone know that. So I want to next go into the high categories. Anyone who's had F2, HIV positive, Hep B, coexisting liver disease. And then this next category I think is really interesting is debilitating fatigue. For those in primary care, that's probably a very common complaint. I'm tired. And I see a lot of my Hep C patients that have had some really dramatic turnarounds in patients who had their Hep C cured. I had one guy who said, I feel like I got 20 years back in my life. I'm much clearer in my thinking and good energy. Porphyria cutaneous tardis, so kind of a blistering in the sun-exposed areas. And then type 2 diabetes. The reason for that is that there's some data showing that if you treat the Hep C, you can actually improve the diabetes or prevent frank progression to diabetes in a pre-diabetic. There are other categories of elevated risk, so MSM, injection drug users, incarcerated, anyone on hemodialysis long-term, HTV-infected women wishing to conceive, and then healthcare workers who have Hep C and want to perform invasive procedures. This is encountered now in our institution. So just to give you an idea of what our Medicaid is paying for, they do all of this, and they're kind of looping down into HIV, Hep B, and coexisting liver disease. Other states are much more draconian, and like I know in the state of Illinois, they only treat F4. Other states are actually much more liberal. So in New York State, it's F1. And so part of that is the own state budgets and also the deal that they've been able to cut with the insurance companies. So I'm going to talk about the two first-line regimens that are recommended by AASLD and IDSA guidelines. The first one is a drug called Harborview, and it's a combination of two antivirals, ledipasvir and sofosbuvir. So just two medicines in one pill. And this is approved for genotype 1, which is about 70% of Hep C patients. The ledipasvir component is a novel target, the NS5A inhibitor, and then sofosbuvir is a nucleotide analog polymerase inhibitor, so kind of the molecular Xerox machine. As I said, it's just one pill once a day, and it's usually for about 12 weeks. This is not a cheap medication. So this is the $1,000 pill you've been reading about in the newspapers. Most people are going to qualify for 12 weeks. A subset of people can get it for 8 weeks. That really brings the price down to $63,000. But then there are some that need the whole 6 months, and that's a very expensive treatment. This is just average wholesale price. I will tell you that the large payers are getting great discounts. So example, the VA, I think, are getting a 40% discount on this. A lot of Medicaids are getting in a 20 to 30% range. So this is the absolute highest you're going to see. So looking at the package insert labeling, patients who are treatment naive, they can have cirrhosis or not, usually you can use 12 weeks. However, if you have a patient who has a lower viral load defined as less than 6 million, an 8-week option is reasonable and can be considered. For those who have been had treatment before, that includes with protease inhibitors or the PEG interferon and ribavirin, they need 12 weeks as well. And then this category who's been treated and cirrhotic, then you need to go a little bit longer, 24 weeks. So there are a couple key drug interactions, not that many, but rifampin, St. John's wort, which is a herbal medication sometimes used for depression. And then more recently, amiodarone has been put on the blacklist. The one thing that I think we've learned is that you can't use acid-suppressing agents, or we use them with caution. The ledipasvir needs an acidic environment, so our pharmacists have been great in kind of counseling patients on if they can go for 12 weeks without that, it'd be best. Otherwise, you need to space them out. There's a couple HIV interactions. The big one is Topranavir. That's like an absolute no-no. Fortunately, we don't use Topranavir that much. And the other one is much more common is tenofovir and ledipasvir. And what happens is the tenofovir levels can go up, and you can more likely get renal issues and Fanconi syndrome. So we just got to watch those people a little bit more closely. So in terms of cure rates, we use something called an SVR. I think Jeff alluded to that. So that stands for sustained viral response. That is a negative viral load 12 weeks after stopping treatment. And for purposes today, I think we can call that a cure. So if we follow these people now long-term, and 99.9% of these people remain viral negative years out. And importantly, SVR is associated with some of those hard outcomes that Jeff alluded to, like survival, but also if you do serial liver biopsies, your fibrosis can improve, the inflammation. So there's lots of other data support this is a good outcome. I just want to point out the cure rates. So remember when Jeff showed that slide of 15 years ago, we were talking about 10 or 20% cure rate, and we're pushing 100% cure rate. This is an intention to treat analysis, and so that means that they had some people who were lost to follow-up. I think there were maybe just a half dozen of people who truly failed. And it didn't really matter if you used ribavirin or if you went longer. These are treatment-naive people, so really amazing cure rates there. So the other medication is considered first line is a drug called Vicurapac. And this is the package insert for how to use them. This is a little bit more complex in that you have to know what your subtype is. It's not just genotype 1. If you know they're 1A, you got to use ribavirin. So ribavirin is an oral medication. It causes a little bit of a rash, and the big thing that we run into more as a side effect is anemia. It can cause a hemolytic anemia, so we have to watch their CBC a little bit more closely, especially in the cirrhotic. And those are the ones who are more likely to bottom out of their hemoglobin. So I want to point out that and similar to the Harborview package insert, cirrhotic patients do need to go a little bit longer, so 24 weeks. And then with the 1Bs, you can get away without using the ribavirin without cirrhotic. If they do have cirrhosis, you do need to have that ribavirin. So what is Vicurapac? It's actually has more antivirals in it than Harborview. It actually has 3 active antivirals. So similar to the ledipasvir, there's an NS5A drug called ombidisvir, and then a protease inhibitor called retiprevir, and then another drug called dasubivir, which is a non-nucleoside, so not totally similar as fosavir. And then they use a HIV medication called ritonavir that helps boost those levels so that it can be dosed BID. So it's a BID regimen. You do need to take it with food, and it's also very well tolerated, just a little bit of fatigue, sometimes a little bit of some insomnia. And it's similar to the Harborview is 12 weeks, a little bit cheaper, so around $10,000 cheaper for the average wholesale price. If you look at the cure rates, they're quite comparable to Harborview with 95 to 98% sustained viral response rate. So really nice cure rates there. So I wanted to just remind us of what patients I think is important. This was a survey that we did of patients for a PCORI grant. And it's a word cloud here. And I think the big thing that jumps out is treatment. But other things that are important to note is some of the symptoms that they really struggle with on a daily basis: fatigue, the depression, and just having this hang over their heads. And so I think we're really need to remind ourselves is how important it is for many of our patients that they get treated and cured. So we are approaching this in a two-pronged approach. The first is to scale up the Project ECHO paradigm so that more primary care doctors can be supported and equipped to take on the treatment with such effective, low side effect profile medications. We really think this is now something that the average primary care doctor can do. So this is a resource that is available for all King County primary care doctors. And so what it is a very short way of thinking about it is it's this morning report on steroids. So we have case reports that are faxed in with kind of the key information. And then you have a multidisciplinary panel that will discuss the case. So a picture of me with Dr. Schuhart, Brian Wood. We have Joe Merrill to provide expertise on the substance abuse and addiction medicine side of things. And then we got people joining from all over the Northwest, from all over WAMI land. So just to give you an idea, people from Alaska here, Boise, up in Bellingham. We even invaded Oregon. I ran it by my OHSU colleagues first, and they're okay with that. But we have mostly primary care doctors, a couple ID. We have a lot of pharmacists and mid-levels who are also joining. And so this is a whole community of learners that help each other out. So in addition to the kind of experience that we provide, sometimes working in the trenches is as valuable as the opinion from the academic medical center, and they often will chime in with some really nice helpful advice. The way we start out is with a didactic, 15-minute didactic on really practical, useful things. We try not to get too much in the esoteric aspects of Hep C. And so a good example would be when we go to the big liver meetings, we try to do a highlight of what were the key talks and the late-breaking news. We have a written consultation that goes back to them. If there's any key trials or any literature that's quoted, I'll follow up with that as a PDF for patients. This is based on situated learning. This basically, we learn best when we're actually dealing with a real patient. So just to very briefly go over the evidence for the safety and efficacy of this. This was published in the New England Journal in 2011 by Dr. Sanjay Pawar, who started this, and I think is actually before in this venue. And it showed that if you compare patients who are being treated by echo versus an academic medical center, their cure rates are absolutely the same. So 57% in Albuquerque versus 58% in the echo site. This was in the PEG interferon ribavirin data, where 45% was considered to be very good. The SAE rate was actually lower in echo, was about 7% versus 14% in New Mexico. We have repeated this study, and we're actually within 2% of these numbers as well. So this has definitely been replicated in addition to University of Washington. This is being expanded to University of Utah, Phoenix, Baylor, University of Chicago, Duke, Harvard, some other places around, not just the United States, but around the world. So the other prong in our approach is to provide a very up-to-date online curriculum, and this is work that Dr. David Spock and Nina Kim and Allergy and Infectious Diseases have really pioneered with the funding from the CDC. These are just some screenshots that are available to everyone. You could go to HTV Online and start accessing this and learning this today. So just wanted to walk you through it. There's some great data on the medications. We'll walk through all the key clinical trials, side effects, things like that. And there's a formalized curriculum. So if you wanted to really get up to speed, you can walk through the epidemiology. There's some nice clinical calculators. And you can download the slide lectures for free. So some of these slides actually came from those. This is an example of the modules that are available. And for this grant, we're having a much more streamlined curriculum that's going to just be hitting the bare essentials. This is an example of some of the lectures and available modules for the medications. So hopefully you can see that we're at a real pivotal time in the Hep C epidemic. If we don't do anything, we're going to really see that tsunami. But I think with a combination of simplified screening criteria, so screening your baby boomers, better staging diagnosis with the AFRI and the FiberSure, and then availability of such resources as the Project ECHO and this curriculum, and the really nice new medications, I think we can really avoid that tsunami. So I just wanted to end with thanks for many people who are helping out with this grant, the folks at the Seattle King County, UW, Department of Health, Dan Lessler, HCA, and then many of our other partners in this project. And I think we'll have a little bit of time for questions, and we'll turn it over to Rachel.